Well, good morning. As Dr. Goldenberg said, I'm going to be discussing various novel therapeutics that we were developing in the lab. And, I'd really like to talk about these for a whole hour, but judging from the response from my last talk that I gave, which a couple of years ago, I'm not going to. So I'm going to avoid a lot of mundane, basic, wet research. What I'm going to talk about is divided into two different parts. So the first part, just to review difficult cases, difficult BCG cases, what to do to try to optimize its management, as well as part two, to then go into and delve into what is new in the horizon in terms of clinical trials, and then finally just talk briefly in the last third of the talk on the different things that are going on at the Prostate Center research, in terms of research. So unfortunately, even with the current most optimal management with aggressive adjuvant chemotherapy in association with adjuvant immunotherapy, BCG, the recurrence rates and progression rates are really poor in all comers of patients with non-muscle invasive bladder cancer. And these range from 40 to 70%, with progression rates that are strikingly very high, 15 to 30%. And if we look at prognosis of T1G3 tumors, which are always considered this so-called superficial disease, these patients still have very worrisome prognosis, and I think we all take this for granted. Shahin is one of the fellows who worked with Studer, and what he showed was in Studer's cohort of T1G3s over the last 15 years, 1/3 actually will eventually die of metastatic bladder cancer, which I thought was very surprising. And when we look at post-resection, which now is the so-called standard of care, so patients with that initial T1G3, they go back and have that re-resection. If you have tumor of T1G3 back in that initial re-resection, your prognosis is very poor. This is not disease-free survival. This is actual survival data going over 60 months from New York, data from New York. So unfortunately, I think this data points out the limitations that we have as urologists and oncologists in treating this what appears to be aggressive disease. And I think that it stems from our limited intravesical therapies that we have. These are Donald Lamb's laws of intravesical therapy. I think we all know this. We want to eradicate any kind of leftover microscopic disease. We want to prevent recurrence of any tumor. We want to prevent tumor progression as well as improve overall survival. And unfortunately, as from the data I showed, we really don't have an agent that fulfills all of these criteria. Well, what do we have? And I think I'm going to be talking about two agents that are considered standard of care now. And the first one is perioperative chemotherapy. Why do we use mitomycin C, and why is it considered standard of care now? And it's from various different RCTs. The largest one is this FIN Bladder 4 study, as shown here. A small study, but still 205 patients were recruited. 2 points from the study that we can learn. One is that those patients who received mitomycin C perioperatively within the first 24 hours did much better compared to those that received it on day one or after day one. And the second point is that mitomycin in association with adjuvant BCG did much better than those who had mitomycin with BCG alternating with interferon. And what this regimen was, BCG interferon, which is why this is not done. And in fact, standard of care now is this protocol here. Richard Sylvester's from the EORTC looked, and he's done a lot of these meta-analyses. We're going through a couple of them today. But in this meta-analysis looking at perioperative chemotherapy, he looked at 7 RCTs, and what he showed that the number needed to treat was about 8.5, with a 39% reduction in recurrence. So this is the real reason why, for the residents, we use mitomycin C in terms of a perioperative sense in the recovery room. In terms of perioperative chemotherapy, from the FIN-4 bladder study, it should be given within the first 24 hours. Number 2 is that I think many other individuals have discussed this and proven this, including this Finnish group, that pretty much you can use any kind of chemotherapy. And I think the real reason why we use mitomycin C is that it probably is the safest. However, if there's any concerns of bladder perforation, you shouldn't be giving this. And although patients probably will not die of this, they will suffer some severe peritonitis and prolonged hospital stay. So it's something that you should not be given if you think you've perforated bladder. I think we all know that. And the Japanese as well have shown that maybe different frequency of installation might be more optimal. So in North America, we're only giving one installation, and as you can see here, there are many Japanese groups who are trying to promote multiple mitomycin C installations after resection. What about the other standard of care for intravesical therapy? Well, that's BCG, which is immunotherapy. And BCG for immunotherapy has been cited by obviously many groups, but unfortunately with relatively limited data. But let's look at the data that we have so far. This was Donald Lamb's review in the European Urology, and it's an older review. But what he showed here is that if we look at BCG and compare it to the various other chemotherapeutics, whether it's mitomycin C, Adriamycin, or thiopurine, that by BCG, given in an adjuvant sense, did better in terms of recurrence and progression. And again, Sylvester showed in a meta-analysis where he compared BCG with all chemotherapeutics in patients with CIS. And what he showed was really patients who received BCG did significantly better, almost twice as good compared to chemotherapy, all combined. So now, as we all know, BCG is now considered the treatment choice of patients with carcinoma in situ. Again, another meta-analysis looking at TA, T1, and CIS, so all comers. This is a large meta-analysis, but again, only 24 trials looking at BCG versus all chemotherapeutics. And remember that although there have been some studies that have shown that maybe one strain is better than the other, this meta-analysis did not show that. And as well, if you look at all of the strains combined versus all chemotherapy combined, patients who took the BCG did better than those with chemotherapy, with one caveat, and that caveat is that you need the maintenance therapy in order to fulfill that advantage. So remember that if you have no maintenance, there is no advantage. With the maintenance, there appears to be advantage, and this advantage reduced the risk rate by about 37%. There was no survival advantage, and I think this is one of the main complaints that many oncologists have in terms of BCG is, well, why are you giving something that doesn't improve survival? And I think the big reason why survival advantage wasn't found on the meta-analysis or any of these studies per se, especially even the large SWOG study, is that the follow-up for all of these studies were very, very short. In fact, the mean follow-up was only 2.5 years. So I don't think we would expect to see survival differences this early on. So now let's talk about the difficult cases of BCG therapy, meaning what do we do in patients who appear to not respond or fail? And I think as clinicians, you have to make sure that we clearly identify why they're not why they're failing or why they're not responding. And this is very important because the management for each one of these are different. Whether it's intolerance, are they actually just not tolerating the BCG? Is it truly refractory? Is the tumor still there even though you're giving them the treatment? Is it resistance? Is it there a slight decrease in tumor size and then a recurrence or growth? Or is it a relapse? Is it something that's come after 6 months of total NED? In terms of BCG intolerance, I think we all know that this is not a benign agent. It does cause some local toxicity, as you can see here. 91% get cystitis. However, fortunately, the major side effects are quite small. I remember when I was a resident, all of our staff always said, well, if you have a good response locally and if they feel really sick, they're going to do really well. And that really isn't true. We know that local side effect profile or systemic side effect profile is not associated with success or efficacy. So you don't use that as a judge to determine whether or not a patient's doing well or not. And I remember one time I had one patient when I was a resident who did really poorly, really sick, and the staff said, oh, that's all he needs, just one, because he responded so well to that one treatment. So that kind of thinking is illogical. When we look at intolerance as well, it also appears that if we get them past that first initial hump of irritative type symptoms, that they appear to tolerate it more. and will not withdraw from therapy. So this is an ERTC trial. I think that is quite heavily quoted, looking at BCG treatment and in a phase 2 open label study. What they showed was that the highest number of dropouts were in the induction period, as we would expect, as well as in the first 3 to 6 months. But with time, if they're able to stick with this course, it appears that they are able to tolerate it more. And again, this might just be due to the fact that those patients who could not tolerate were weeded out, the Will Rogers phenomenon. But really, I think what we should try to do at least is to do everything we can so that they get past this initial hump, so that maybe they can tolerate it more and maybe even tolerate maintenance therapy. The other issue too is that if they don't get their full 6 courses, they will have a higher risk of progression and failure. And this is just one study of many that has proven that. If they can't get their full induction course, and also with the meta-analysis, their maintenance, they will not do well. So you have to take this in consideration. If they truly are intolerant to BCG, you're going to have to consider doing something else, obviously, and realizing that these patients have a very high risk of failure. Well, what can we do then to try to maximize tolerance? Well, and I think a lot of us do this already, but unfortunately there's only one study to actually prove that it is safe, meaning does not alter efficacy, and that's to give a fluoroquinolone. And I think that we all know that quinolones are very active against BCG, and one of the concerns is that if we give an agent to try to minimize local toxicity as well as systemic toxicity, we might be affecting the effect or the ability, the cancer fighting ability of BCG. What this study shows, and this is a French study looking at in a double-blind fashion, the effects of giving ofloxacin twice, 6 hours and 12 hours, to see whether or not, firstly, we can reduce the symptoms, and secondly, if efficacy is altered. And what they showed is that although it doesn't affect the common symptoms like the very severe cystitis and such, what it does do, however, is reduce grade 3 to 4 symptoms. So the very severe effects of BCGiosis, severe fevers, infections, systemic disease, etc. The other thing too as well is that they were able to show that if you were to give ofloxacin, you had a higher chance of actually completing the course of treatment. And as well, probably the most important thing from this that we can gather is that there really was no effect on the efficacy in this group of patients. What about reducing the dose? So this is a Spanish study looking at dose reduction. This is 1/3 dose, and again, which is a common theme with all superficial bladder cancer studies, small patient numbers, 50 versus 44. But in this study, what they showed was that even the reduction of BCG to 1/3 did not affect the efficacy of the drug. And as well, there was no difference in recurrence rates or progression rates. So this might be an option too. However, if we then carry this forward to even reducing it further, so this is the same group, same Spanish group, looking at 1/3 dose versus 1/6 dose versus mitomycin C. And not surprisingly, those patients who received mitomycin C did the worst. Patients with 1/6 dose did the second worst, and patients with 1/3 dose did the best. So what this suggests is that our limits of dose reduction in BCG appears to be about 1/3. Whether or not this correlates to other strains, we don't know. But I think that this is at least one option you can do to patients who appear to be intolerant to BCGs to try to dose reduce them to 1/3. What about BCG refractory disease? And I put this Herman cartoon up because of the 50-50 chance. Unfortunately, if you truly fail BCG, and there is not an adequate response, you have a really poor prognosis. And in fact, unfortunately as well, looking at the long retrospective data from New York, 40 to 50% actually will fail BCG. So 40 to 50% will fail. And if you have tumor at 6 months, so if you're a true non-responder, there's no response later on. So those patients should have aggressive therapy. So in this report, there were actually no responders of those 19 patients who had tumor at 6 months cystoscopy. And only 11% of those with tumor at 6 months remain tumor-free at 18 months. So I guess all of this data suggests that we should be very aggressive to patients who are true BCG refractory disease. Sure.
Is this irrespective of whether they have CIS or purely?
This is all comers, TAT1 CIS. And what I thought was surprising is that the numbers were actually quite small. But these were the patients that actually failed in their retrospective database. Dr. McLaughlin?
So BCG and mitomycin not affect the outcome of those that really slow progression.
I think that if we were to actually look at it long enough, we probably would see survival data with BCG. But what BCG does for sure is it slows the progression and reduces the recurrence rate. Absolutely. And mitomycin C does not. This theme of the dangers of BCG refractory disease is shown in many different studies, and this is just another one looking at 236 patients, where if you have a tumor at your first cystoscopy post-BCG treatment, they're going to progress. So half of them progressed, and 35% of those with first cysto actually died of metastatic disease. So don't take this lightly. If you have a patient who has tumor at the time of their first cystoscopy after your BCG failure, you probably should be aggressive with them, especially if they're a surgical candidate. And what about the last group then, in terms of the so-called BCG failures, BCG relapse? Well, again, I think this is a common theme. I think that if patients do require more BCG, that their prognosis is worse. This is the only data I could find in terms of BCG relapse, but again, it's well quoted. It's a Catalona paper from 1987, and what he showed was that the more courses of BCG that you require, so this is a pre-maintenance era, so the more 6-week doses of BCG that you require, the higher rate of progression, higher rate of metastases. I think this is very logical, and if you have a patient who requires a lot of BCG, please consider more aggressive therapy. Well, what is that more aggressive therapy? First, one thing that we can consider maybe is valrubicin. Again, I'm not a big fan of valrubicin just because of the data. It was approved by the FDA in 1998, and amazingly, it was approved based on a single study of 90 patients. This is a phase 2 open-label study, and actually downloaded the FDA discussion and their vote. And they've actually voted unanimously 10-0 in favor of approving this agent based on the single study, primarily because of the fact there were no alternatives at the time. And even to date, there are no alternatives. But I think this is a common theme that, and we'll see this when we discuss some of the future clinical trials in Intravesical Therapeutics, is that most of them are phase 2 trials. And I think the companies are now using this data to try to get approval from the FDA. But in any event, it's not available in Canada currently. And initially they said it was due to manufacturing issues. But actually, when you look at the FDA website, it's primarily due to contamination issues. Valrubicin was contaminated with multiple different other agents. So it wasn't until they actually cleaned up their manufacturing, that it was approved. And it was just recently approved. It will be available next few months, actually, in the United States. And I'm not sure if it's going to be available in Canada. What about mitomycin C for BCG failures? Again, not efficacious at all. Very few studies, and all of the studies suggest that these patients are, again, destined to failure if you give them mitomycin C. So it's not a very good alternative. It is not recommended. What about the third option? And I think the third option is something that a lot of us do. It's the reinduction of BCG with interferon. What is the rationale for that? Well, interferon is an immunomodulator. We really don't know how it works, but through non-specific and specific effects on the tumor, whether it's through BCG or not, it appears to have an additive, at least, and maybe synergistic effects on bladder cancer with BCG. And unfortunately, again, this is another common thing that I'm saying a lot. I hope it don't sound like a broken record. There really isn't that much good data. But I can tell you this. There's a lot more data for this than valrubicin, which is already FDA approved. This is the first phase 2 study by Mike O'Donnell, 40 patients. These are BCG failures. And what he showed was that induction with BCG using a third dose with interferon and then reinduction with 1/10 dose and maintenance for those who have failure had a higher response than expected. And this is a higher response that you expect compared to Studer's data that I presented earlier, in that 50% are actually disease-free long-term, 44 months right after. This was this has been updated, and I didn't get the updated slide because it has actually been published. It's been published in review papers, but this was the only official paper coming out looking at a phase 2 trial of interferon and BCG in both the BCG naive and BCG failure patients. Again, it's a larger study. It was multi-institution. What they showed was that, again, they had relatively good response rates that was higher than expected for BCG failures and even for BCG patients when you give 1/3 the dose of BCG in addition to interferon. So I think that this is a reasonable option, but I think that if you are going to give this to patients, that this is something that you have to explain to them that is still considered experimental, but something that is an option, especially in those patients who are very strongly opposed to having cystectomy, or those that really want to maintain, obviously, their bladder. So what about other agents and BCG or clinical trials in the pipeline? Well, as you can see here, there really isn't too much. If we look at what is available in terms of in the next 5 years, we can see that there are a lot of chemotherapeutics. Again, I think maybe beating the same horse here. Looking at gemcitabine combination, gemcitabine with mitomycin, looking at docetaxel, looking at other taxanes, or looking at even a prodrug of mitomycin. I think it's a common theme. We're trying to maximize or optimize delivery methods of chemotherapies to the bladder. We're also looking at novel delivery methods, and I'll be talking about that in a sec. And I think the only phase 3 trial that is available for bladder right now is this hypothermia. So I'll be talking about that in a sec too. But really, the bottom line is that there are very few clinical trials right now, unfortunately, for BCG, which is the impetus for obviously some of the work going on at the Prostate Center. Let's briefly talk about thermochemotherapy. This is just hypothermia. And we all know that hypothermia is just another form of stress, and with that stress comes cell death, potentially. It appears to be additive or synergistic when applied to chemotherapeutic agents, and this is just not in the bladder cancer model, but various other model systems. So there's this potential to try to maximize the effect of the chemotherapeutic when it's applied intravesically. And as you can see here, all that's done is that the urine in the bladder is just heated up to about 40 degrees. And as you can see here, this is the Synergo, just one of the many different hypothermia methods. But in this is the company that is sponsoring the large phase 3 study that is still open, and they're expecting about 300 patients. What they're doing is just increasing the temperature to about 46 degrees. And they're comparing BCG versus mitomycin and Synergo. And what they showed in their phase 2 data are relatively good results. The 2-year recurrence rates in BCG naive is only 24%, all comers, TA to CIS, which I think is quite good. And if we look at BCG failure, again, we still hit that 50% mark rate. So maybe not be so efficacious in patients who have failed BCG. EMDA is something that's already available, and all EMDA is just an application of a small current. In the lab, we use current to try to open up the cell membrane to allow delivery of various agents, whether it's DNA, plasmids, whatever, into the cells. And this is another method of just opening up the bladder cancer cells to allow for an increased delivery of chemotherapy into their cells. In fact, I talked to one of the sales agents last year about this. It's actually being very well used in Europe, but not in North America just yet, I don't think. And what, again, the real reason why it's probably not accepted as widespread use is that they're very small studies. In fact, when I looked at them, most of them are in abstract form still, and it's not FDA approved, but still being used in Europe. And it appears to be better than mitomycin alone, but similar to BCG. And this is, again, in a phase 2 clinical trial. So I think all of this data, all the numbers seem to point of our limitations of current intravesical therapies. And with that, I think we should all recognize that if patients are not going into a clinical trial, we should strongly consider cystectomy. And we all know that delaying cystectomy greater than 12 weeks in someone with muscle-invasive disease is associated with decreased survival. And it's because of this, as in addition to the fact of the limitations, especially in those patients who do not respond to BCG, that I think we should be considering cystectomy earlier on than later. And this is a paradigm shift that is already starting in the United States. This is a Guido Del Bagni's study looking at different cohorts of patients. This is just a retrospective comparison of outcomes in a historical cohort versus a contemporary cohort in BCG failures. In a historical cohort, it would be very, very unlikely that they would remove a bladder in patients with T1 bladder cancer. As you can see here, of the 129 patients of the 589 that had a BCG recurrence with T1, 65 underwent radical cystectomy. And they claim that one of the reasons why they have better outcomes in terms of survival, as you can see here, these are the disease specific. This is actually the patients that are alive, recur, and then eventually die of their bladder cancer. So this is death from disease up here, bladder cancer. I'm not sure if I can. Death from bladder cancer is up here. And as you can see here, there appears to be an improvement in outcomes. But again, you're comparing apples and oranges, different eras, different surgical techniques. But one of the things that they claim is that maybe because we're being more aggressive in these T1, G3 patients, they're having better outcomes. So still not considered a standard of care, but I really think that in those patients with a long outcome, so the younger patients, even with T1, G3 disease, cystectomy might be an option. So just, although obviously it's a controversial statement, that's something to at least consider, especially considering the poor outcomes, long-term outcomes of patients with BCG. So now we're going to part 2 of the talk, looking at novel therapeutics. And I think, as I said earlier, one of the real reasons that we're looking at this at the Prostate Center is we've realized that there are very limited intravesical therapeutics, especially novel targeted intravesical therapeutics. And as you can see here, this was me my first year. Actually, it was at on Broadway, looking for grants. And this is a more seasoned veteran looking for writing grants. He's actually in the pool, so hopefully one day I'll be able to write grants in the pool and not in the East Hastings. So as I mentioned, targeted therapy is our goal. Chemotherapy and BCG is trying to kill everything, wiping out everything. You're going to damage normal cells as well. Targeted therapy is like a sniper, trying to find and killing those cells with tiny little bullets, those cells that you really want to kill and not harming normal cells. And I think that the intravesical route is the ideal approach, for many reasons. It's easily accessible. The drug can be in contact for hours. There are potential reasons why a drug can stick to the bladder wall, and there's potential reasons why the drug may not be systemically absorbed. As well, because we have the ability to perform cystoscopy, we can not only retrieve data to look at the effect of the drug on the tumor, but as well response of the drug on the tumor in terms of changes microscopically, protein changes, et cetera, et cetera. And our first target I want to talk about is something called heat shock protein 27. Sorry for this ugly looking cartoon. I think I just put this up here just to show you how important this protein is. Now, apoptosis is programmed cell death, as we all know. And this protein that we're studying at the Prostate Center appears to be important at many different parts of this cascade to cell death. And remember that it appears that in many different cancers, including bladder cancer, that the upregulation of this protein may be just one of the reasons why these cells are able to not only be resistant to treatment, but also to progress and maybe even metastasize. So HSP27 is a chaperone protein. It is upregulated in times of stress. So you can define stress as being heat, chemotherapy, radiotherapy, whatever, anything that stresses the cell And what it does is it binds to other proteins to protect that. And as you can see here, it also helps in the refolding of various different proteins and is highly expressed in many different tumors. And this is a molecule that we're looking at in both breast, prostate, lung cancer. If we look at our tissue expression, so this is a tissue microarray, so these are just spotted tumors on a single slide, and we look at the expression of this protein, you can see here that it's very highly expressed in these tumors, whereas normal tissue has very little expression. And this data is consistent with 4 other papers. So we believe that it's an important target in bladder cancer. And again, sorry about this basic science slide. Hope I don't put you to sleep. Just take this in consideration. If we look at a bladder cancer cell that is artificially overexpressing HSP27, as you can see here, this black dot just means that there's a higher amount of HSP27. These cells grow faster. And also, when we treat it with chemotherapy, don't die as much compared to the normal cells that do not express this, as you can see here. So it appears, again, we just wanted to prove that the expression of this protein confers some kind of resistance to chemotherapy. So one of the ways that we're looking at to try to suppress this in cancer cells is using a molecule called OGX427. And this is an antisense drug. I'm sure you're all familiar with antisense. It's just a double-stranded piece of DNA that binds to the RNA to then decrease the production of this protein. Again, sorry for this slide, but all I wanted to show here was that this drug really does suppress the expression of this protein. So you can see here, dark, light, nothing. Dark, light, nothing, so that if we look at this agent and treat it in the lab, we can get significant suppression of this protein. And then when we actually look at this in mice, looking at tumors, when we inject these tumors into the mice and their mice bellies and their back, and we inject this drug into their blood, or into their abdomen to have a systemic absorption of this, we see that indeed that we can suppress tumor size compared to a control, which is called scramble. As well, this effect appears to be even better when we give it with chemotherapy. So remember that paclitaxel is a drug that is being studied for bladder cancer, as well as given intrathecally. And when we combine it, we're getting a much better effect compared to the control. One of the problems, however, looking at tumors that are in their skin, the subcutaneous tumor, is that it's very difficult to correlate this data with data that we're going to inject into the bladder. So remember that just because it responds maybe when we give it systemically, may not be applicable in a bladder tumor sense of the word. So we can't really determine how effective in terms of a profile of absorption and true downregulation of this protein it will be when we give it into the bladder. So what we've developed over at the Prostate Center is a tumor model where we're injecting human cancer cells called the KU7. This is a human metastatic bladder cancer cell line that we're injecting into nude mice so that the mice don't reject it. And as you can see here, the tumors grow really nice and big in their bladders. So using this, and we're using something called the luciferase expression system. All that means is that we can use fluorescence to determine their size real time using this very sensitive microscope. We can actually see these tumors in a real-time sense in their bladders. In the good old days, mice would have to be sacrificed to determine whether or not there was actually a tumor there or not. So these days, we don't have to do that. So we can actually determine changes in size as well as whether or not there's actually even any tumor at the time of the initiation of treatment real time. As we see here, you see these tumors here, it does correlate with the expression of this luciferase. And not only that, this tumor here correlates to the MRI. So the system really is effective and has been validated both histologically and also via MRI. So what about OGX427? So what happens to this drug when we inject it into the bladder? Well, these are just normal mouse bladders that we looked at, and we're staining for this drug. So the brown is the drug here. And as you can see, this drug really does get into the cells. And this is just naked antisense. And as you can see here, there's very little getting into the muscular layers of the bladder wall. As well as we look at the other tissues, again, this is a really benign agent, and especially when we give it in the bladder, and we can see here when we do histologic analysis of mice that were given this drug in the bladder, there really are no changes either in the kidney, liver, or the perivesical fat. When we then look at the growth patterns after we instill this drug into those mice that have the tumors that I showed you earlier, we have a definite advantage in those given this drug. So I can see here, the dotted line here are the mouse tumors with the tumors in the bladder, then treated with this drug in the bladder, and as you can see, there's a definite advantage of those given the drug versus this control. We then looked at the mice after treatment to see whether or not the drug was actually doing what it was supposed to do and not doing some kind of non-specific effects. And we can see here that when we look at this target, HSP27, it really was downregulated compared to the control after treatment. So it appears to be doing what it's supposed to be doing, and it is clearly having effect on the tumor. So it was this preclinical data that resulted in the NCIC grant that we got a couple years ago, looking at this agent in the bladder, and I'm happy to report that it is now Health Canada approved and will be accruing patients in the next month. So please, if you have any patients with difficult to treat, please let us enroll them in this trial. And all we are doing is a phase 1 trial looking at expression of this target as well as the effects of this target, whether or not we can actually suppress HSP27 in patients who are given this drug in the bladder. And this is both in patients going for a radical cystectomy or patients who are just going for transurethral resection, so first-time diagnosis. And again, this is just the protocol. They're just going to be having 3 to 5 treatments of this drug, and they're going to have this in their bladder for 2 hours, and we'll just assess, the expression of this protein after treatment. So please, if you have any patients who might fulfill this criteria, let us enroll them. So target number 2, and this is the work that we've been doing with Dr. Rennie, who's in the audience, looking at viruses in the bladder. And remember that oncolytic viruses are viruses that specifically target cancer cells, and because of various mechanisms do not affect normal cells. So as you can see here, this is VSV, this bullet-shaped virus. So this virus specifically targets cancer cells and does not target normal cells, and it targets cancer cells and kills them. Amazing, with very amazing efficacy when you actually look at it in our animal models. And the real reason we think this drug just targets cancer cells is because those cells that have a normal interferon system or signaling pathway, which are normal cells, are able to get rid of the virus through whichever mechanism. Those that are infected appear to die, or the virus has very little efficacy because of the upregulation of interferon. Who knows? But I think the real reason is that those cancer cells have an aberrant interferon system and are therefore a target for interferon. And one of the reasons may be that the expression of interferon receptors decreased. And this is what Yoshi, one of our postdocs, has shown, that maybe the lack of expression of this receptor, especially in the higher grade tumors, might be one of the reasons why VSV has a specific oncolytic action. And again, this preclinical work had led to yet another grant with the Canadian Cancer Society. It's now called the CCSRI. Looking at this, we're going to characterize this virus further with the help of Dr. Rennie in the lab. So further preclinical work, but some preliminary data suggests that when we inject this virus into those same mice that I showed to you before with the human bladder cancers in their bladders, we're getting very striking effects here. So almost clearing out these bladder tumors completely. So it's very interesting work. I think in that it gives us the ability to treat the bladder tumors with what appears to be a very non-toxic agent. So other targets that we're looking at, the cytokine pathway. We're also looking at intravesical siRNA in the bladder, as well as various different mucoadhesive chemotherapeutics with very sticky chemotherapies and sticky antisense as well. And this is work with Dr. Hellenberg at UBC. So acknowledgements, I just want to thank, obviously, Dr. Glave, Dr. Rennie, who are co-PIs in the 2 NCIC grants, as well as Yoshi Matsui is here, who's a postdoc working with me, as well as various other postdocs here, Boris, Kevin, as well as a pathologist, Linan, and also the research associates. Thank you very much.